Hi everyone, this is Derek Erstad with Surgery Snapshots, and in this video we will be reviewing cholecystitis disease pathogenesis and how this information informs operative difficulty. There are three main learning points to this video. First, we will review the stepwise causal process of cholecystitis disease pathogenesis. Second, we will discuss differences between visceral and somatic pain and how these processes inform the temporal course of disease. Finally, we will discuss how to leverage this more nuanced understanding of cholecystitis pathogenesis in the preoperative setting to inform the likely operative difficulty based on specific patient and imaging factors. Thanks for watching. Okay, so we'll first start with a discussion of cholecystitis pathogenesis, which occurs in a stepwise causal process. The first step is cystic duct obstruction. I have shown a cartoon on screen left of a gallbladder with stones. Oftentimes, one of these stones will lodge and obstruct the cystic duct at some point along its length, which I have shown with a red circle. Now, the gallbladder wall is made of three layers: epithelia, muscularis, and adventitia. Epithelial columnar cells that are lining the lumen of the gallbladder absorb fluid and salt, concentrating bile, and also secrete mucin. With obstruction, the dynamic balance between bile reflux into the gallbladder, fluid absorption, and electrolyte exchange is disrupted, and the net result is gallbladder distension with fluid accumulation. Now, the second step to cholecystitis pathogenesis is that distension leads to increased luminal pressure. So as the gallbladder continues to distend, it places increased surface tension on the wall. As we know from our cardiology days, Laplace's equation of wall stress is notable for tension being directly proportional to luminal radius. But eventually, this increased distension will result in a drop in wall compliance, at which point further stretching is limited or halted. At this point, there will be substantial increases in the intraluminal pressure, and for reference, the normal pressure within a gallbladder is anywhere from 0 to 5 millimeters of mercury. In states of cholecystitis, it can reach pressures of 15 to 30. Step 3 of cholecystitis pathogenesis is that increased luminal pressure leads to ischemia. The best way to understand this is by looking at a capillary model of microcirculation and oxygen delivery. On the diagram, I have shown approximate pressures for arterioles, which is 30 to 35, capillaries 20 to 25, and venules 10 to 15. Now, as obstruction leads to increased distension, which leads to increased luminal pressure, eventually the pressure exerted on the wall will be greater than the pressure of the capillary system. This process first disrupts venous outflow, which leads to congestion, and further exacerbates wall pressure. On a pragmatic note, it is this initial process of venous congestion that leads to gallbladder wall edema, which is one of the radiographic hallmarks of cholecystitis. A normal wall is 1 to 3 millimeters in diameter, and we set a cutoff of 4 millimeters for cholecystitis. Now, eventually this process will halt oxygen delivery at capillary beds and arterial inflow altogether. Ischemia will now ensue. Now, when we examine the gallbladder wall again, we see that the majority of the vessels are located in the outer adventitial layer, and oxygen delivery primarily occurs from out to in. This also means that the epithelia or mucosa is most vulnerable to ischemic insults, and the ischemic process will then progress in a transmural way from the lumen to the outer wall over time. Importantly, the columnar epithelia that line the lumen are heavily ATP and oxygen dependent for homeostatic functions such as electrolyte exchange, mucus secretion, and maintenance of tight junctions. So as the mucosa becomes ischemic, these processes fail and they feed back positively to exacerbate the ischemic process. Step 4 is that ischemia leads to inflammation. While the inflammatory cascade is very complex, there are some basic critical processes that are noteworthy for cholecystitis. One of these is to distinguish between cell death by apoptosis versus necrosis. Apoptosis is a process of controlled cell death that is well contained and results in little to no innate inflammatory response. Apoptosis is ATP dependent, meaning oxygen dependent, and it is an orderly process. Conversely, necrosis is a chaotic process by which cells under duress lyse and release intracellular contents into the surrounding milieu. This release of contents, many of which function as damage-associated molecular patterns or DAMPs, stimulate a profound innate inflammatory response, including recruitment of neutrophils. Now, neutrophils release devastating granzymes that destroy everything in sight, including healthy tissue, thereby amplifying the inflammatory cascade. Now, importantly, necrosis occurs when cells are devoid of oxygen and ATP, which occurs in states of ischemia as seen with cholecystitis. So cholecystitis incurs inflammation because of ischemia and lack of ATP when cells die. Okay, so step 5 to the cholecystitis pathogenic process is that inflammation leads to visceral afferent pain. So as we said before, the ischemic process of cholecystitis works from mucosa to adventitia due to the architectural blood supply of the gallbladder wall. Nerves run throughout the gallbladder wall, and some of these nerve fibers include visceral afferent pain fibers, which can be affected by these pathologic changes before the ischemia and the inflammatory processes become transmural. The visceral afferent nerves of the gallbladder signal to the celiac axis, and the lived experience of a patient is a sense of vague epigastric pain with possible radiation to the back. When patients have irritated afferents leading to the celiac axis, which also occurs with other foregut pathologies such as peptic ulcer disease and pancreatitis, patients may also describe a feeling like a rod or a knife stabbing through them in the epigastric region. Cholecystitis, especially during this earlier phase, can be more challenging to diagnose given that the differential for this type of pain includes any organ with celiac afferent nerves. This is the most often scenario with biliary colic, and the surgeon is then reliant on identifying other positive factors, usually with imaging, to isolate the gallbladder as the source. Finally, drivers of visceral afferent pain from the gallbladder can include mechanoreceptors, such as stretch and pressure, ischemic signals, typically from necrosis, and inflammatory signals. Step 6 is the final process in this causal model of cholecystitis that we have created. In this step, transmural ischemia and inflammation of the gallbladder wall is complete, and this leads to parietal peritoneal irritation and right upper quadrant focal pain. I have shown a sagittal view diagram of the liver and gallbladder on screen right to further demonstrate this point. An inflamed gallbladder will physically touch the anterior abdominal wall parietal peritoneum. This leads to local inflammation of the peritoneum, which results in dermatomal somatic nerve pain with focal tenderness. Okay, but this leads to the question of how does an inflamed gallbladder cause focal parietal peritoneal tenderness when the peritoneum in that area is presumably non-ischemic and unharmed? One important concept to at least partly explain this process is the impact of paracrine inflammatory signaling on pain fiber sensitivity. Release of inflammatory mediators from a gallbladder with transmural inflammation, such as prostaglandins, bradykinin, among others, are taken up by the parietal peritoneal tissue when the two structures directly touch. Inflammatory signals such as these then directly influence the somatic afferent pain fibers embedded in the abdominal wall. Specifically, these mediators lower the firing threshold for the action potential of nociceptive or pain-sensing nerves in the area. The net result is that even slight perturbations, such as gentle palpation with physical exam, can lead to exquisite tenderness because the peritoneal nociceptive nerves are triggered in this sensitive state. I have shown two action potential diagrams for pain-sensing nerves on the screen. On the left in blue is a nerve under normal conditions with elevated firing threshold. On the right in red is a nerve with a reduced firing threshold due to inflammatory signaling. This concept also explains why, if you develop redness or swelling around a wound such as a cut or a scrape, even gentle touches in the surrounding area can be painful even though that tissue was not directly damaged in the nearby wound. Local inflammation has sensitized the surrounding pain fibers. As the inflammation resolves during the healing process, the nerves will normalize their firing thresholds and the local tenderness will resolve. Okay, so now that we have a solid explanatory model for cholecystitis pathogenesis, we can apply this information to better understand the temporal course of the disease process. In the early phase, defined by obstruction, distension, increased luminal pressure, and non-transmural ischemia and inflammation, the patient will present with visceral afferent pain signaling to the celiac axis. This will manifest as vague epigastric pain with possible radiation to the back. This is the most common symptom for early onset acute cholecystitis. But as this process progresses, eventually there will be significant ischemia, transmural inflammation, and parietal peritoneal irritation. Then the patient's symptoms will be defined by focal right upper quadrant tenderness that often wraps around the flank and back. Now, I think one takeaway for trainees is to not write off cholecystitis even if the patient is not focally tender in the right upper quadrant, because you may be catching them early in the disease process. Now, can we leverage this information to predict which of our patients may have a more challenging gallbladder operatively? And I think the answer to that question, at least to a small degree, is yes. To get at this, let's first look at how men and women distribute adipose differently. Women tend to carry excess weight more in the subcutaneous tissues, including the hips and thighs. Conversely, men carry excess weight as visceral fat within the abdomen. This is why overweight men will oftentimes have skinny arms and legs but a large protuberant abdomen. Okay, now how does gender-based differential fat distribution relate to gallbladder surgery? Well, if you look at the sagittal diagram I've shown here, I am demonstrating the point that overweight men with high visceral adipose will often shield their gallbladder from touching the parietal peritoneum with a large omentum or pericolic fat. In these cases, the patient can have a profoundly inflamed and ischemic gallbladder and yet not experience right upper quadrant focal tenderness because the parietal peritoneum is shielded. This can also happen with women, but it is less common. The second factor that often tracks closely with obesity and metabolic syndrome is diabetes. Long-term diabetes can cause microangiopathies and peripheral neuropathies. Similar to losing sensation in the feet, diabetics can also lose sensation in their visceral afferent nerves. These individuals are less sensitive to pathologic changes in their gallbladder. If you take these two factors together, high visceral adiposity shrouding the gallbladder and diabetic neuropathy, there is a much higher chance that the patient has findings of chronic cholecystitis due to recurrent, underappreciated insults that may make the operation more challenging. Often these patients will have GERD or generally feel unwell, and it is difficult for them to distinguish between gallbladder pain and these other chronic symptoms. By the time symptoms become bad enough to present to the hospital, the gallbladder is often in a terrible state of acute and chronic disease. This brings me to my second point, which is that it is also more likely for these patients to present at a more progressed state with transmural ischemia and possibly gangrenous tissue, which again will make the operation more challenging. So taken together, be wary of a cholecystitis consult in older obese males with diabetes. The consulting physician may say something like, only a couple of days of symptoms, but not really tender, so not so bad. That is a trick, and you should be prepared for a challenging case. Now, to wrap things up, I want to show two case examples that nicely demonstrate these points. On screen left is the sagittal CT of a 45-year-old man with a BMI of 35 and type 2 diabetes on insulin who was diagnosed with cholecystitis. On screen right is the sagittal CT of a 42-year-old woman with a BMI of 33 and no major medical issues, also diagnosed with cholecystitis. So now let's point out some anatomy. The gallbladders are highlighted in green. The subcutaneous fat for each patient is highlighted in purple, and you can see that on a relative basis, the female patient has more subcutaneous adipose. Now let's point out the visceral fat in yellow, and you can see here that the male has significantly more visceral fat. Now, when we look at the fundus for each gallbladder, we can see that the male patient with increased visceral fat has shielded the gallbladder from touching the parietal peritoneum. This patient presented with multiple prior episodes of epigastric pain and generally feeling unwell, but had no significant right upper quadrant tenderness. Conversely, for the patient on the right with limited visceral fat, the fundus is directly touching the parietal peritoneum, and consistent with that observation, the patient presented with 24 hours of epigastric pain, followed by development of exquisite right upper quadrant tenderness that brought her to the hospital. Finally, I want to point out that we can see significant inflammatory changes in the surrounding hepatic parenchyma near the gallbladder for the male patient, which is another clue that this case might be quite difficult. Now, for these cases, the male patient ended up getting a subtotal gallbladder with a drain, and the female patient ended up getting a standard cholecystectomy. Based upon their histories and imaging information, we had some clues to indicate the relative difficulty of each operation. Okay, here are intraoperative images of the gallbladders for each patient. For our male patient on screen left, the gallbladder was densely adhesed to surrounding fat and was gangrenous with stigmata of chronic disease. This patient required a subtotal with drain placement. Conversely, the patient on screen right, who presented in a more classic fashion, the gallbladder is clearly inflamed, but it is free from surrounding structures and had straightforward anatomy that was treated with standard cholecystectomy. So that is my summary of cholecystitis pathogenesis and how to leverage those insights to inform your clinical judgment and patient management. I hope you found this helpful, and thank you for watching.